It is a very proud moment for all of us. The pediatric nephrology department, the seeds of which was laid by the great Dr. Nammalwar, the legendary Dr. Nammalwar, the father figure of pediatric nephrology in southern part of India, who is sitting right in front of us. He, along with Dr. Vijay Kumar, followed by our own young brigade, Dr. Sudha, Dr. Kalaivani, and all, they nourished this department and brought this to great heights. And today we are able to organize this webmaster series on congenital anomalies, CAKUT, in association with the Indian Society of Pediatric Nephrology, International Federation of Kidney Foundation, Women in Nephrology India, and Indian Academy of Pediatrics, along with Department of Pediatrics, Mehta Hospitals. I welcome all the learned speakers who assembled here, Dr. Suttanuthap, Dr. Kimberly Reddy, on all the people who are here, Dr. Nammalwar sir, Dr. Gaurishankar sir, Dr. Amrish Jain, Dr. Suresh Balan, President IAP, Dr. Lutha Kumaraswamy, and all of you to this wonderful academic feast. I welcome all the delegates who have been there in the online to learn from the best experiences of all the speakers, and let knowledge and wisdom go to all corners of our country to the aid of all our needy children. I welcome you all. Thank you very much.
I also request Kannan sir to introduce Thangavelu sir, our senior pediatrician.
Sir, Kalaivani, I'll just, when not require introduction by my close friend, I'll start introducing Professor B.R. Nammalwar. To shorten the timing, we want to save time. I'm very fortunate to introduce my teacher and mentor, Professor Nammalwar. What I am here is mainly because of his teachings. He's a senior pediatric nephrologist and former professor of pediatric nephrology, Institute of Child Health in Madras Medical College. He obtained his DM pediatric nephrology, I think, around 1982. He is considered as a founding father of pediatric nephrology. Through his characteristic combination of academic excellence and mentorship, he has inspired many pediatricians and pediatric nephrologists to provide service to children with kidney diseases. The Indian Society of Pediatric Nephrology has presented a Lifetime Achievement Award to Dr. Professor B.R. Nammalwar for his outstanding contributions to the care of children with kidney diseases. After his retirement from Madras Medical College, he established pediatric nephrology centers in Kanchi Kamakodi Children's Hospital, later in Mehta Multi-Speciality Hospitals. Apart from providing clinical services, B.R. is an educator par excellence. He is known for his remarkable teaching skills among pediatricians and adult nephrologists alike. He founded the Kids Kidney Care Trust to spread awareness of pediatric nephrology among the physicians. He received multiple awards for teaching by his parent institutions, state level and national bodies such as MGR Tamil Nadu, MGR Medical University, Indian Academy of Pediatrics, and Indian Medical Association. His textbook, The Principles and Practice of Pediatric Nephrology, written entirely by pediatric nephrologists in India, is a key reference manual. He has also published many scientific articles in national and international journals and has been an invited speaker in many prestigious orations. He is also an emeritus editor of Popular Indian Journal of Pediatrics. Apart from the few things, when he started the pediatric nephrology department way back in 1985-87, he used to come even the middle of the night to start peritoneal dialysis. At that time, nobody would have had any knowledge of peritoneal dialysis. I still remember when I was a postgraduate, he used to come in the middle of the night, 1 o'clock, 2 o'clock, to start the peritoneal dialysis for children. All of us learned not only knowledge, we learned a lot of compassionate attitude from him. So, welcome you, sir, Professor B.R. Nammalwar, sir.
Thank you.
Sir, Professor B.R. and sir, I suppose to introduce the topic and...
Thank you, Dr. Thangavelu, for such kind words. I really feel sort of little sort of excited to hear so many good things about me. I'll tell this to my wife. She's always been saying this. She has not heard this, like I wish she was next to me. Anyway, I am to introduce the subject to our speakers. Good evening to all of you, my friends. I'm honored. Thank you, Dr. Amrish Jain and Dr. Kalaivani, for this wonderful opportunity you have given me and a privilege. CAKUT is an acronym for congenital anomalies of the kidney and urinary tract. To be honest with you, 40 years ago, I had not heard of this word CAKUT. It's something new. CAKUT results from abnormal development of the urinary system and is present for birth, although the abnormality can become apparent later in life. For example, hypoplastic kidneys, bilateral hypoplastic kidney can present at a later age as CKD. The causes of CKD are complex. It could be a combination of genetic and environmental factors. Individuals with CAKUT can have one or multiple kidney urinary tract abnormalities. CAKUT varies in severity. CAKUT can present at birth with life-threatening kidney failure or as an end-stage kidney disease. It is the commonest cause of chronic kidney failure in childhood. I'm sure most of us will agree. It leads the cause of CKD, is the cause of CKD commonest cause of CKD in pediatric practice. The abnormalities it is a common cause. The abnormalities can result in recurrent urinary tract infection, as in VUR, or as obstruction to urine outflow, as in post-withdrawal, both of which damage the kidneys. And you will agree with me, for any one postgrad pediatric nephrologist, CAKUT constitutes 1/3 of his clinical problems. But when it comes to the pediatric urologist, it's much more for him. I'm grateful to Dr. Kalaiwani and Dr. Amir for choosing some wonderful topics and for spacing them so well. It's a perfect job. And both of them have chosen speakers who are luminaries in their own sphere. We must thank all of us, must thank them for spending so much of time on this planning of this program. With these words, I open the portals of the vista of knowledge for the next 1 month. Thank you very much.
Thank you, sir. I just want to introduce our Head of Department of Pediatrics, Mehta Children's Hospital, at NC Gauri Shankar, Senior Consultant Pediatrics. He's a pediatric pulmonologist and bronchoscopist, who has done more than 1,000 bronchoscopies, including in the newborn. He's a master trainer, asthma training module, IAP, and he's also editor and management guidelines for common pediatric problem. He was emeritus editor of Indian Journal of Pediatrics. And a lot of things. He's much interested in developing all the pediatric subspecialties and encourages the specialties to grow to support the general pediatrics. Over to Dr. Gauri Shankar.
Good evening, all. Thank you, sir, for the kind words. My pleasant duty to introduce the ISPN President, Dr. Susan Uthap, who had done her pediatrics from KM Hospital and Seth GS Medical College, Mumbai, who had completed her DM Nephrology and DNB Nephrology from Government Medical College, Trivandrum. She is the Professor and Head Department of Pediatric Nephrology, SAT Hospital, Government Medical College, Trivandrum. She is the Honorary Consultant Pediatric Nephrologist, Sri Chitra Institute of Science and Technology. She is also the member, Board of Studies, Kerala Institute of University of Health Sciences. She is a faculty of Institute of Management, Government of Kerala. She had many publications in national and international journals. She is a member of the draft committee of ISPN guidelines. She is the coordinator for ISN SRC program, SAT with CCHMC USA. Her special interests are pediatric CKD and dialysis. Her honors are really extremely worthful, like first rank in Mahatma Gandhi University for first, second, and final MBBS. She is the best outgoing student from Kotte Medical College in 1991, winner of Ambadi Bhaskara Menon Gold Medal in 1991, and she is the winner of H.L. Trivedi Gold Medal in DNB Nephrology in 2004. She is a fellow of International Society of Nephrology in 2012. Also had her fellowship at Cincinnati Children's Hospital Medical Center, Ohio, USA, 2012. May I request Dr. Susan Uthap, Madam, to have a few words.
Thank you, Dr. Gauri Shankar, and good evening to all. Dr. B.R. Namalwar, Doyen of Pediatric Nephrology in South India, as well as mentor for all of us, Dr. Thangavelu sir, Dr. Gauri Shankar, Dr. Kannan, Dr. Suresh Balan, and of course, Dr. Kalaimani. It is indeed a great pleasure to be with you all this evening. And on behalf of the Indian Society of Pediatric Nephrology, I would like to congratulate Mehta's Children's Hospital Pediatric Nephrology team, as well as Dr. Kalaimani, for this fourth in the series of IPNA webinars. And definitely, as Dr. Namalwar has already said, the topics selected, each time she selects such unique topics and wonderful academic fees, that is already 3 in the series is already gone. And we are looking forward to the fourth one, where eminent faculty members and others from all over the world are joining us to teach us on congenital anomaly of kidneys and urinary tract, starting from the development and ending with the transplant management. And I am indeed indebted to her for giving me this opportunity. And I am proudly, I am congratulating you and wishing all the best for this program. Thank you.
Now, it's my pleasant duty to introduce the Secretary of ISPN, Dr. Aditi Sinha. She is the Associate Professor, Division of Nephrology, Department of Pediatrics, All India Institute of Medical Sciences, New Delhi. Her areas of research interest are pathogenesis and therapy of steroid-sensitive and steroid-resistant nephrotic syndrome, pathogenesis and outcomes of hemolytic uremic syndrome. She also had received the Dr. H.P. Dingley Memorial Award from ICMR for research in pediatrics in 2018. She is a Commonwealth Medical Fellow, Manchester, UK in 2018, and she is the Junior Representative IPNA Council between 2014 to 2017. May I now request Dr. Aditi Sinha to say a few words.
Thank you, sir. And I really thank the organizers for inviting us to this excellent academic series of webinars. We are very happy to have the Indian Society of Pediatric Nephrology associate with this webinar series. And we are very grateful to Professor Namalwar sir and Dr. Kalaimani for organizing this series year after year, beginning with the COVID times when we began this webinar series in 2020. It is an excellent time to be a postgraduate or a trainee in pediatric nephrology in the country right now, because of the many opportunities for learning that students have been provided through hard work from pediatric nephrology colleagues from across the country. And I am very grateful to Dr. Kalaimani for ensuring that this goes on year after year through these webinar series. And we are looking forward to the entire webinar series, and we are sure that it will be an excellent opportunity for trainees across the country and elsewhere to learn and benefit from them. Thank you.
Thank you, madam. Now, I will invite the woman in nephrology, the first and foremost, Dr. Urmila Anand, to say a few words.
Madam is not available. She just conveyed her wishes.
Okay.
She has difficulty in joining.
Okay, over to you, Kalai.
Kalai, Samir Mehta joined. I'll introduce Samir
Yes,
Mehta
sir.
and Suresh Balan too.
Sure,
Before
sir.
you introduced Kimberly and Amir Jain.
Dr. Lata Kumaraswamy is also there, sir. Like
Yeah.
once you introduce Dr. Samir Mehta.
Okay.
Sir.
Welcome, Mr. Samir. Samir is the Vice Chairman of Mehta Group of Hospitals. He's one of the very few administrators who is also very friendly with the clinicians. And he's one of the most, he's the Vice Chairman of the hospital, one of the most respected private hospitals in India with 90 years of history. Mr. Samir Mehta is a regular speaker, advisor at international conference on healthcare. He is a great scholar and passionate reader about ethical practice and health economics. He's always very encouraging person for the clinician to do more research and contribute in academics. Most of the academic and research encouragement is from the administration from Samir Mehta. He also serves on board of IIT Madras Rural and Technology Incubator. So I invite Mr. Samir Mehta to offer his felicitation.
Thank you, Dr. Thangavelu and Dr. Gauri Shankar, Dr. Kalaimani and the whole team. I think we are a family, and it's a great privilege and pride that I get to see such a wonderful program organized and hosted, where we are the stewards of knowledge sharing, even when a king is perhaps anointed in a country where perhaps millions watch. The ones that matter are all here on this call. So with that, I wish you great learning, and more importantly, to all of them and all of you out there, please come share time with us, share research with us, and share insights and knowledge with us. And I think wish you all wonderful health and more smiles and contentment to days to come. But as with all knowledge, not too much contentment. Thank you.
Thank you, Shamir. I'll just introduce Dr. Suresh Balan before handing over to Kalaivani. Professor Suresh Balan is a professor from Kanyakumari Medical College, very close to Susan Uthu's place. So he's a very staunch IAPN, involved in a lot of academic activities. Currently, he is the president of IAP Tamil Nadu State Chapter. He has got a lot of plans to provide both academically as well as to the service of the children. I invite Professor Suresh Balan to offer his felicitation.
Very good evening to all. Respected Professor Namalwa sir, the legendary teacher and the father of pediatric nephrology. My teacher, my mentor, my guru and guide, Professor Dr. Thangavelu sir. My friend, Professor of Pediatrics, Mehta Hospital, Dr. Gauri Shankar. My friend, Dr. Edwin Fernando, Dr. Kalaivani Madam, Dr. Susan Udip, all the dignitaries and the eminent speakers who have joined online for this wonderful academic event, which is being organized by the Department of Pediatric Nephrology at the Mehta's Hospital. As Dr. Professor Thangavelu sir has told, it's really a excellent academic institution. The Mehta's Hospital is being there for 90 years, doing a very great service, as well as an academic programs for children and for all the budding pediatricians throughout our country. And I'm very happy that today they are organizing the 4th IPNA endorsed WEBMASTER series events, along with various international and national organizations in nephrology. So this particular topic of congenital anomalies of kidney and the urinary tract is very important at the primary care physician level, pediatrician level, to the intensivist level. So we see quite a lot of cases in the peripheries at the primary levels, with the even neonate babies presenting with hydronephrosis, congenital hydronephrosis. And in our place, we see a lot of children with urinary stones. So this is an important area, like nephrology. And I'm very sure that this particular series of academic programs will be useful for all the nephrologists as well as all the pediatricians who joined this program. I really congratulate the entire team, Dr. Kalaivani Madam, and all the team members who have organized ever since 2020. 2020, they had about 34 webinars, and 21, they had 18 webinars. 22, they had 15 webinars, and now they are planned for 12 webinars. And it's really a great job they are doing. And I wish this entire program will be a grand success for all of us. Thank you for this wonderful opportunity. Thanks. Thank you.
Thank you, Professor Suresh Balan. Kalaivani, I'll take one more minute just to welcome Professor Edwin Fernando.
Yes,
He's a nephrologist of, I could not see him in the panel from the frame. I welcome Professor Edwin Fernando, nephrologist of Stanley Medical College, a person with a rare combination of knowledge, skill, and compassion attitudes with very sick renal patients. Welcome you, sir. Over to Dr. Kalaivani.
Thank you so much, sir. Now I request Lata Kumarasamy, President of IFKF WKA, to say a few words.
So thank you, Kalaivani. Welcome to everybody to this IPNA endorsed WebMaster Series 2023. It's an honor to be part of this program and this knowledge sharing. So on behalf of the International Federation of Kidney Foundations, World Kidney Alliance, and Tanker Foundation, I welcome you all and say thank you. IFKF WKA is an organization of foundations from all over the world which wants to promote better kidney health for all and best care for people affected with kidney disease. We're a group of organizations that's trying to make a difference. We also, along with International Society of Nephrology, observe World Kidney Day. Tanker Foundation is a foundation founded by Dr. Georgie Abraham to help the underprivileged with kidney ailments. We run dialysis centers. We help 850 people. And we try to make a difference. There's a lot more to be done. So with no further delay, I just want to say that we are so honored and grateful to be part of this wonderful series. Congratulations to Mehta Hospitals, to Dr. Kalaivani and your wonderful team. There are so many eminent experts who are going to be conducting these webinars, and we have so much to learn from all of you. So best wishes and thank you again.
Thank you so much, ma'am. Thanks for the kind introduction. And I think we are towards the end of the program, and we'll just deliver a short note of thanks, and we'll start with the scientific
Kalaivani,
Yes, sir.
Professor Kimberly and Professor Amish Jain may be very well known to you, but they should also be known to the audience.
So, sir, after the
please
vote of
introduce
thanks,
them.
the scientific session starts with Amrish Jain introduction, sir. Sir, can you say a few words, sir, about the series so that we can deliver the vote of thanks and move on to the scientific program?
Okay, of course. Thank you. Professor BRN has already deliberated on this topic. When initially all the pediatric subspecialties are growing up, I was in fact knowing that they are going to take over the pediatrics and they will be away from pediatrics. And now I know that the growth of specialty has enriched other specialties. Now you see a lot of, not rare disease, a lot of children dengue now recovering because of your renal support. A lot of children with transient myelitis and Guillain-Barré syndrome going home walking from ICU because of the nephrology support. I see, it opens a very new avenue that nephrology is supporting, not only nephrology supports all acute care problems of children. Whether it is autoimmune hemolytic anemia, I've seen these are the list of patients what we have managed in the last few months. Autoimmune hemolytic anemia, transient myelitis, poisoning, and so many children are benefited because of your renal support from the pediatric nephrology services. So naturally, specialty growth is going to save more and more kids. Thank you for that. I think you will, without wasting time, we'll go into the program. Thank you, Kalaivani.
Thank you so much, sir. Thank you for the support. And I deem it a great honor, and it's a privilege to propose a vote of thanks on this memorable occasion. And first of all, I give my glory to the Almighty God for making this occasion a resound success. And first and foremost, I thank the International Pediatric Nephrology Association. And this post-COVID era has really made us familiar with the online platform, and we are able to share the knowledge globally. And I should really thank IPNA for funding the webinar series for the last 3 years, and this is our 4th year. And this series is completely focused on CAKUT, that is congenital anomalies of kidney and urinary tract. And all these talks will be delivered by experts. And we all should understand the success of any program is always faculty dependent. And I'm very sure that we'll have the best of them. And taking the success story of 2020, 22, 23, we have sketched out this year a scientific program, and I planned to make it as an annual event. And Dr. Mehta Hospital being one of the best teaching institute, our administration had always been a pillar of support for conducting all academic activities. And we would like to thank our chairman, Mr. Mr. Dilip Mehta, our vice chairman, Mr. Samir Mehta, our director, Dr. Pranav Mehta, Dr. Kannan, our medical director, Dr. Edwin Fernando, senior nephrologist, Dr. S. Saravana Kumar, our unit head, Mehta Hospital, Dr. Dinesh, our head clinical operations, to make this event a very big success. And I am also grateful to all senior pediatricians at Mehta Hospital, Dr. RSS sir, Dr. L. Subramaniam sir, Dr. Gauri Shankar sir, Dr. Nerinjalian sir, Dr. Annamalai sir, and Dr. Prem Kumar sir for making this event and supporting us always. And making a dream come true is not just achieved by dream. It requires a lot of moral support, and such support is always rendered by pediatric team to us. And I'm really thankful to Dr. Namalwar sir and late M. Vijay Kumar sir for acting as a guiding force for us. And the strength of any scientific program is going to have the best of faculties. I can assure you that you will be hearing from experts as well. And my real thanks to all national and international faculties for their contribution. And all talks in the series are going to be a clinically oriented talks. And I'm pretty sure at the end of this series, we all would gain a better knowledge, which can be transformed to a better patient care as well. And I extend my thanks to my own colleagues, Dr. Uma Maheshwari, Dr. Sunil Reddy. A big thanks to our medical social worker who had been working really hard, Mr. Kapil Arasu. And I also extend my thanks to IT department, our branding team who is helping us to design beautiful invites for each webinars. And I also extend my thanks to the whole Mehta family. Last but not the least, I should really thank my own family and my kids for supporting for this program as well. Thank you. I think now we can go on to the scientific program. So today the talk is going to be on normal and abnormal development of kidney, a primer on CAKUT. And the moderator is going to be Dr. Amrish Jain, who's our course director as well. Dr. Amrish Jain is a medical director, pediatric kidney transplant program at Children's Hospital of Michigan, USA. And he has won numerous awards, and he is also won the Best Teacher Award. And I request Dr. Amrish Jain to introduce our speaker.
Yeah, thank you so much, Dr. Kalaivani, and thank you so much, all of you, for joining today. It has been an honor and a pleasure for me to be associated with this webinar for the last few years now. I feel that this webinar has become a way to come back to India and be involved in whole family. I feel that Mehta Hospital and the entire all the physicians there are part of my big family. And I pay, it is a great way to come back home in a way. That's what I feel it as. And without taking much time, we want to start the session, and we are very excited that this is the inaugural session. And I can tell you that we have the best speaker, here today. And I want to introduce Dr. Kimberly Reddy, who is the Associate Professor and Chief of Nephrology at Children's Hospital of Montefiore and Albert Einstein College of Medicine, Bronx, New York. She has basic science interest research, she has translation interest research, and she also does clinical research in kidney development and glomerular diseases. She is particularly interested in nephrotic syndrome, glomerular diseases, and congenital abnormalities of the kidneys and urinary tract. She is a very well-known leader here. She is a part of multiple professional organizations in the form of American Society of Pediatric Nephrology, American Academy of Pediatrics, and the Neonatal Kidney Collaborative. In 2021, she was elected for the membership in the Leo M. Davidoff Society, recognizing her long-term commitment to excellence in teaching medical students. Recently, I also got to work with her. She was the chair of the program committee and was responsible for preparing an entire session in the American Society of Pediatric Nephrology conference, which just concluded. It was a huge success. She is a National Institute of Health funded researcher. Her research funding is in bone and chronic kidney disease alkali response pilot trial, the BICAP pilot trial, and cell-specific partitioning defect, PAR1AB, deletion effects on renal repair. She does clinical research in glomerular and chronic kidney disease, including the NIH-funded nephrotic syndrome study, the Neptune study, which is very well known, and the Cure Glomerular Nephropathy, the Cure GN study, which is again a huge success. I can go on and on and on about her, and but I want everybody to hear from her. And we are so excited that she's going to be talking about the normal and abnormal development of the kidneys and introduce us to what CAKUT is And over to you, Dr. Kimberly.
So first of all, thank you so much for this very kind introduction. Let me just share my screen here. And it is such an honor to be invited to open up this really exciting webinar. I saw all the incoming speakers and they look great. I just want to make sure everyone can hear me okay. Yes? Good. All right. So I'm going to try today to give an overview of both normal and abnormal development of the kidney and talk a little bit about the various abnormalities that we see in children with CAKUT. So the objectives today are not only to talk about the stages of normal kidney development, but also a bit about the mechanisms. And then to really describe the spectrum of CAKUT that we see from both mild to severe manifestations. And then ultimately, we can use this knowledge to recognize how genetic defects that affect various kidney developmental pathways can really manifest as various forms of CAKUT. And I won't be able to go into depth in all of these spaces, but this will, I hope, be a setup for some of the future talks, which will go into greater depth into each space. So I'm going to use a case-based approach today to kind of review this. And I'm going to start off with a patient that is close to my heart because of their issues. This is a 5-year-old girl who gets referred for an evaluation of an elevated serum creatinine of 0.6 milligrams per deciliter. And her past medical history is notable for preterm birth at 24 weeks gestation with a 3-month stay in the neonatal intensive care unit. Her height is 105 centimeters. Her weight is about 20 kilos, so she's growing. But when we look at her on her exam, we note that her blood pressure is elevated at 105/65. This is based on these new guidelines from 2017 in the US, the American Academy of Pediatrics. This would be at greater than the 90th percentile, which we consider to be elevated, but not high blood pressure yet. And we can use various calculators. And again, I don't have the time to go in depth of this, but right now in the US, we tend to use 2 different ways of estimating kidney function. We have our bedside Schwartz, which many of you may be familiar with. And by that formula, we get an estimated GFR of 72 mLs per minute, 0.173 meters squared, so mildly decreased. And with the newer formula, the CKID U25 formula, we get an even slightly lower estimate of 59. So again, some degree of mild to moderate kidney function impairment. However, when we do our workup for her, we find that the kidney ultrasound is reported as normal. We don't find any blood or protein in the urine. And so the question here is, what went wrong in this child's kidney development? And why do we see this elevated creatinine and decreased function? So to kind of frame this a bit, I'd like to step back to review the early stages of kidney development, which many of you may be familiar with. So as you may know, there are 3 primitive kidneys that form during development. And we like to say they form from the head to the tail. So the first one is the pronephros, which it forms and then involutes in about the 3rd week of gestation. Then the next primitive kidney is the mesonephros. And these are actually tubules that do have excretory units. But we know that the mesonephros, which forms in the 4th week, then involutes as well. However, from that mesonephros, we have our mesonephric duct, which is very important because it becomes the source of our ureteric bud or Wolffian duct, which is going to interact with the metanephros, our 3rd primitive kidney, to actually form the adult kidney. And again, these are forming from the caudal to the tail area, as we would say. So this is where your definitive kidney forms. And again, this begins around the 5th week of gestation. So when we go further forward, so we have our ureteric bed that invades the metanephric mesenchyme. And I'm going to talk a little bit about this later, but there are very important signaling pathways that guide that ureteric bud, such that only one ureteric bud forms and that ureteric bud reaches the metanephric mesenchyme. And then as the ureteric bud enters the metanephric mesenchyme, there are signals between the metanephric mesenchyme to the ureteric bud and vice versa, from the ureteric bud back to the metanephric mesenchyme, that regulate branching. So this tree-like structure here, this is actually a imaging picture of what a mouse kidney looks like. You can see that we have these beautiful branches forming, and the number of branches is critically important because that is going to determine the number of nephrons in the kidney. And we know that there's a wide variation from 200,000 to 2 million nephrons in human kidneys. And so the number of these branches is going to have a big impact on our ultimate nephron endowment later on in life. And at the tip of each branch, there are, again, these signaling pathways that first drive a conversion of the metanephric mesenchyme, the mesenchymal cells, into epithelial cells. And they form this sphere or vesicle, the renal vesicle. And then these undergo various shape changes to make the definitive kidney, so that you have this comma shape and ultimately the S shape nephron. And the most important point of this is that the location between these cells and the collecting duct is in part what determines what segment of nephron they form, such that the cells that are closest to the ureteric bud will form the distal tubule. This mid portion here will form the proximal tubule, and those that are most far away from the ureteric bud are the ones that are going to form the podocyte. And as you may know, that there are both endothelial progenitor cells as well as invading endothelial cells that will drive migration of endothelial cells into this vascular cleft, and that is going to be what forms your glomerular capillaries. And the podocyte, which I won't have a lot of time to talk about today, undergoes this shape change from these cuboidal epithelial cells into the beautiful octopus-like structure that we know in the mature podocyte. And this is just another view of this process. Again, you have your renal vesicle, your C-shaped body, your S-shaped body, and here is showing you the podocyte differentiation, where you have, again, this cuboidal epithelial cells that then become the more octopus-like cells that extend foot processes that interdigitate and form our glomerular filtration barrier. And again, there are a whole nother session could be had about all of the developmental processes that regulate this and how that impacts our children that have glomerular disease. So what does this look like in human kidney development? So this is some histology pictures just to demonstrate these various structures as you look through human gestation. So as many of you may know, our deepest nephrons, the ones that are closest to the medulla, are the first to develop, and we develop our nephrons in a centrifugal fashion from the inside out. So here you can see in this 16-week human kidney that there is a fully formed glomerulus. And then if you look in this nephrogenic zone, as we call it, that is right in the top of the cortex, you may be able to identify some of the structures that I mentioned are present. In the developing kidney, for example, S-shaped and C-shaped nephrons. And then you can see as you move forward, you have certainly increasing numbers and layers of glomeruli as you move from 16 to 21 to 27 to then this term infant. And you can see that there are many, many more layers of glomeruli that are forming during this time point. And this is critically important. Because again, the number of nephrons you form is in part related to the gestation at which you were born. So just to summarize these different stages, again, we have our pronephros forming in our 3rd week, our mesonephros in our 4th week. At around the same time as the mesonephros, you have your bladder formation beginning with the urogenital sinus separating from the rectum and fusing with the mesonephric duct. The metanephros, as I mentioned, it develops at the 5th embryonic week. And between the 4th and 7th week of gestation, you have formation of that urinary bladder, such that by the time your first metanephric glomeruli form, which is around 9 weeks gestation, and you really start your initial urine production, you have an ability for that urine to collect within the bladder. Between the 10th and 12th weeks of gestation, you have formation of your renal pelvis and calyces. The ureteric walls develop their muscular later, and the bladder differentiates into both longitudinal and circular muscle fibers. And again, nephrogenesis is not complete until our full 36 weeks gestation. So this is just a picture of what nephrogenesis looks like over time. You can see this is the gestational age by weeks, and this is the number of nephrons that form. And again, here's our ureteric bed. These are our first nephrons. And you can see then there's this exponential growth here of nephrons between the 10th and 30 weeks of gestation. And why is this important? So when we think about the number of nephrons and the time that you are born, if you are born at this extremely preterm birth, like the patient in my case, and the 25-week gestation or 24-week gestation, you can see that you are the number of nephrons that you still have to form, it's almost 2/3 are left in the last trimester. So if you're born here, you are born with a significantly lower number of nephrons at birth. And what we know is that there are many factors that then affect your nephrogenesis after birth. There is some nephrogenesis that occurs, but there is evidence that it does stop early, and that this leads ultimately to a decrease in nephron endowment over time. So not only do we have the fact that the child is born preterm before nephron development is continued, there may be reasons why the baby was born preterm. Perhaps there were placental issues that may also impact how that even the earlier development happens, such as the ureteric bud branching, which, as I mentioned, determines your number of nephrons. Then we add that to the fact that the baby is then going to be exposed to many toxins after birth, potentially episodes of sepsis, hypotension, other potentially inadequate or suboptimal nutrition. And that may further injure some of those nascent nephrons, may alter their development. And then later on, we know that these children may have increased risk for obesity. They may develop high blood pressure. If they eat a high salt diet, perhaps this also interacts. And so overall, we're seeing in population studies higher risk of chronic kidney disease or end-stage kidney disease in these children that are born preterm. And just to highlight that, this was a recent publication from an analysis of a peanut trial, which was a trial of neonates born less than 28 weeks gestation, where they were treated with erythropoietin. But this was looking more at a 2-year outcome from these babies, whether they had elevated blood pressure or signs of decreased kidney function or albuminuria. And what you can see here in this summary slide is that already about 18% of the extremely low for gestational age neonates had decreased kidney function, like the child in our case. They had some degree of albuminuria. I said there was no proteinuria, but I didn't give you the microalbumin. And then elevated blood pressure was also common. Up to 22 to 40% had elevated blood pressures, like the patient in our case. So we know that they're even early on after birth, being born preterm may have significant impact on your kidney function and blood pressure. And this is just another study looking at the national NHANES database in the US, where we use low birth weight as a surrogate for preterm birth. Again, oftentimes we don't have gestational age available in all of these databases. And this just points out that if we use the newer estimates for estimating equations for looking at kidney function, like the U25, we identify that up to 30% of these children born low birth weight had reduced kidney function as compared to children with normal birth weight. So that highlights the importance of preterm birth as one way that we wind up with a congenital abnormality of the kidney or urinary tract. But what about another case? So this is a 2-month-old boy who was referred for evaluation of left renal agenesis. And he was noted to have a solitary kidney on his prenatal imaging. However, otherwise, this was an uncomplicated pregnancy with normal amniotic fluid. And when we do the renal ultrasound after birth, we note there is a solitary right kidney. It has normal echogenicity. It is 6.5 centimeters, which gives us a 98.7th percentile when we plot it on our growth charts. So this indicates that there is some level of compensatory hypertrophy of this solitary kidney. So what went wrong in this child's kidney development? So first, I want to highlight that we know that CAKUT is very common. So up to 1 in 500 births are reported to have some form of kidney abnormality. And we know that this can range from very mild to severe. So the most common, I think, that we see is urinary tract dilation. Now, sometimes this turns out that it resolves after birth and it does not appear to cause any issues with the child long-term. Ectopic kidneys are not uncommon. I will talk a little bit more about multicystic dysplastic kidneys a little bit later. We know that we can have renal dysplasia, and as in this case, renal agenesis, and I'll talk again also about obstructive uropathy. So why do we have solitary kidneys? I don't have the time to talk about all of the signaling pathways that are involved with ureteric bud branching, but I will mention that one of the key pathways is known as GDNF or RET signaling. So the metanephric mesenchyme secretes GDNF, which is a growth factor, which binds the RET receptors on the ureteric buds. And this drives not only the invasion of the ureteric bud into the metanephric mesenchyme, but also contributes to ureteric bud branching. And again, these reciprocal signals are critical for not only ureteric bud branching, but also ultimately differentiation of that cap mesenchyme. And so what we know is that there are many signals that regulate the number of ureteric buds that form, where they form, and whether or not they reach the metanephric mesenchyme. And what we know is that if the ureteric bud does not reach the metanephric mesenchyme, if for the signaling pathways are disrupted, that the metanephric mesenchyme undergoes apoptosis, and that is how we develop renal agenesis, where we have at least the one absent kidney. And certainly if you did further testing to look for function of it by a MAG3 renal scan, you would identify no functional kidney. So how about another case? We have here now a 5-year-old little girl who comes to us for evaluation of recurrent febrile urinary tract infections. And when we examine her, what we find is there's this significant abnormality of the iris, we call it the keyhole sign. And when we look we do the evaluation for these recurrent febrile UTIs using a VCUG, you can see the classic finding of reflux bilaterally into the kidneys. So what went wrong in this case? What causes vesicoureteral reflux? So I wanted to highlight here that there are, as I indicated, many growth factors that affect this invasion of the ureteric bud into the metanephric mesenchyme, and including some factors that restrict the outgrowth to a single ureteric bud. And so if you have defects in those factors, sometimes what happens is you actually get multiple ureteric buds. And this is likely how we get duplicated kidneys, duplicated collecting systems. Now, sometimes this is simply a duplex kidney where the ureters may join together to make one ureter before it enters into the bladder. But I'm showing you here the more severe cases where you actually have duplicated kidneys. And the classic is that the upper pole ureter is ectopic and often obstructed, whereas there is reflux into the lower pole ureter. Even if you do not form 2 ureteric buds, defects of this processing of the signaling between the ureteric bud and the metanephric mesenchyme likely contributes to the development of vesicoureteral reflux. And again, in the most severe case, your ureteric bud does not reach the metanephric mesenchyme, and this is when you get renal agenesis. So what are the signaling pathways that regulate this? I already mentioned GDNF and RET, but there are other signaling pathways that are also very important in this process. So this is just a picture here of the ureteric bud. And a really important point here is that those mesenchymal cells are really a special progenitor cell population. So progenitor cells are those that can repopulate, right? They have the ability to multiply and make a progenitor population that is programmed to form those future nephrons. So they are self-renewing, but are pre-programmed towards the nephron progenitor state. And what we know is that there's a fine balance between those signaling pathways that promote differentiation. So many of these are transcription factors that initiate a whole program of downstream gene activation when they bind the DNA in the nucleus. So for example, PAX2 is a great example of one of these differentiation factors. And these differentiation factors are finely balanced with factors such as 6-1 in the human kidney or 6-2 in the mouse that maintain this progenitor cell population. And if you have any imbalance between these two processes, what you end up getting is perhaps premature differentiation, loss of your progenitor population, and ultimately a hypoplastic kidney with too few nephrons. Or if you have a failure to differentiate, this can lead to dysplasia, which we'll talk a little bit more about. And this is just showing you that these are just a few of the factors. There are so many factors that are involved in the kidney development pathways that I don't have time to talk about all of them. I will mention that we know that Wnt signaling is a very important process that really drives the conversion of the metanephric mesenchyme into epithelial cells. And then there are multiple transcription factors that get activated in a fashion to then drive the maturation from the CAT mesenchyme into our pretubular aggregate, our renal vesicle, and ultimately, as I showed you, the different patterned formation of the nephrons. And I'm just going to highlight a few of these because they may look familiar to you if you have had any children with various forms of abnormal kidney development. For example, 6-IO1 and PAX2 are very commonly identified monogenic causes of congenital abnormalities of the kidney and urinary tract. So the case I showed you was a classic case of a patient with renal coloboma syndrome, which is caused by autosomal dominant or de novo mutations in the gene called PAX2. So PAX2 is an important transcription factor, and this is what it looks like in the developing kidney. You can see it's expressed in both the ureteric bud and the CAT mesenchyme, so it's important in both of those spaces. And it therefore has various manifestations, including reflux. Again, it's important in the ureteric bud differentiation, but it also affects that differentiation from CAT mesenchyme into renal vesicle, and thus you can also see kidney hypoplasia. And because PAX2 is also important in eye development, you can see the optic nerve coloboma that I showed you. An important point is that these findings can be very subtle, and sometimes you actually have to do a detailed ophthalmologic exam to identify them, which highlights the importance of potentially diagnosing some of these problems, genetic causes of CAKUT, because you will look for extrarenal manifestations. So how common is this? So there was a very nice paper from the European group with the ESCAPE study that looked at some of these common gene mutations that are inherited in an autosomal dominant fashion. And what you can see here is up to 17% of the children in that cohort that had the renal hypodysplasia phenotype had mutations. And the most common ones were the PAX2 that I mentioned, but also a gene HNF1 beta, which is also known as TCF2, which causes renal cysts and diabetes syndrome, but also a variety of other manifestations of CAKUT. And also the IO1 and 6-1, which is associated with branchiootorenal syndrome. And now I know that you were going to have a whole nother talk about genetic diseases, so I'm not going to go into depth about all of these, but just to give you a sense that these are not uncommon. And then to highlight again that these are all transcription factors that are expressed in the metanephric mesenchymal progenitor cells, and thus defects in that process, the differentiation of the metanephric mesenchyme into the more differentiated nephrons, is really the point at which these factors play a role and thus lead to this manifestation with renal hypodysplasia. All right, so moving on to another case. This is a child that is unfortunately diagnosed prenatally with multicystic dysplastic kidneys. And I've shown you here sort of the classic picture by ultrasound of a multicystic dysplastic kidney, where you have these multiple cysts with minimal intervening parenchyma. If you look on a gross anatomy picture, this is what a multicystic dysplastic kidney looks like. And if you look at histology of dysplasia, the classic is you have these undifferentiated cells that are surrounded by a mesenchyme. And the idea here is that there is this defect in the conversion of mesenchyme into epithelial cells. You can even have abnormal findings like cartilage in dysplastic kidney. So what's happening here? So again, this is really a defect in that mesenchymal to epithelial transition. Typically, you have a small echogenic kidney. Sometimes you have cysts. You can have the cystic form with multicystic dysplastic kidneys. Certainly, if you did the MAG3 scan, right, the classic finding on renal imaging is that you will have no perfusion of a multicystic dysplastic kidney. And again, you get these primitive ducts with this fibromuscular collar. You can even have abnormal findings of metaplastic cartilage and bone in the kidneys, even basement membrane thickening of the primitive ducts, and even nerves that can be found on histology. So what about other genetic factors in CAKUT? So in this particular form of kidney disease, the multicystic dysplastic kidney, I think it's increasingly being recognized that copy number variants are playing an important role. And so what are copy number variants? So this is when you have deletions and or duplications of pieces of chromosomes. So it's not the entire chromosome, but it is a significant portion of them. And this is just one study that that has looked at this in the multicystic dysplastic kidneys, and it shows that there is a substantial proportion of these infants that presented with multicystic dysplastic kidneys that had deletions or duplications of micro deletions or duplications identified. And you can see here that at least one of them involved a gene called HNF1 beta, which is, again, a common gene, one of the more common genes that is either deleted or deleted in the setting of a chromosomal deletion in CAKUT. So this is 17q12 locus. So how common is this? Well, this was a very nice study out of a group from Columbia in New York that looked at this in various cohorts of children with CAKUT. And what you can see is that when they looked at the overall number of copy variants on the top here, you can see that the prevalence of copy number variants was much higher in the children with CAKUT versus the controls in the black line here. And now, if they looked at what the different types of the CAKUT that were most likely to present with copy number variants, what you can see is that Ka, which encompasses renal agenesis, hypoplasia, dysplasia, or multicystic dysplastic kidney, they were the most common group to have a copy number of variant identified. It was a little less common if you had reflux, and this is, again, the control population. And this is just showing you the spectrum of abnormalities. So this is overall in CAKUT, maybe about 4% of the total cohort had these variants, and the yellow bar here is whether it was deletion, the blue is duplication. So you can see overall deletion was the most common. And again, those with agenesis, hypoplasia, dysplasia, or multicystic dysplastic kidney in this cohort, up to 7% had a copy number variant identified. So what about the other forms of CAKUT that we see? And again, so reflux, for example, it was more like 1%. The ectopic or horseshoe kidney, similarly, only about 1%. Posturethral valves had actually a fair more number of duplications, but again, much less common than if you looked at those kinds of syndromes affecting the upper urinary tract. And then this just highlights those genes that are most commonly affected in CAKUT. And again, you're going to have an entire talk on this, so I'm not going to go into all of these. But again, I think for myself clinically, but also in various studies, HNF1 beta is recurrently one of the top transcription factors identified. It is an autosomal, it can be autosomal dominant manifestations, although it really has a heterogeneous manifestation. So children with the same gene deletion or mutation may manifest quite differently, everything from echogenic kidneys to renal hypodysplasia, renal cyst diabetes syndrome, and many of you may know it can also be associated with hypomagnesemia, hyperuricemia. And again, I don't have the time to go into all the details, but I think that these are increasingly being recognized, and it's very important because they can have extrarenal manifestations. And if you know the child has one of these mutations, you may follow them differently. And again, these are the copy number variants. In my experience, the 17q12, which again encompasses HNF1 beta, is a very common one. What about environmental risk factors for CAKUT? So we do know that there are various factors in mothers that can increase the risks of CAKUT. So for example, vitamin A deficiency, maternal diabetes, and obesity are associated with increased risk for CAKUT. So I think it is important that we take, as always, a very detailed history from our parents about the pregnancy. So when should you suspect a genetic cause of CAKUT? So for me, certainly if you see any evidence of extrarenal manifestations, if you have a family history where multiple family members are affected, and I think that those children who have, as I showed you, kidney hypodysplasia or aplasia, it is more likely that they're going to have a genetic factor, whether it's a copy number variant or a genetic mutation, than those children with isolated mild hydronephrosis, isolated UPJ obstruction, vesicular-ureteral reflux, or post-urethral valves. And I will say that in our clinical practice, we are doing more and more genetic testing in general in children that we follow for various disorders. Certainly children with glomerular disease, we're doing a lot of genetic testing. We haven't quite expanded our genetic testing approaches to the children with CAKUT, but I think this is an evolving space, especially as we learn more about the potential extrarenal manifestations. And certainly, you know, for families that want to have more children, understanding whether this is genetic or not might have impact on their family planning. So here's, I think, my last case that I'm going to talk about today. This is a 2-month-old which with unilateral hydronephrosis. And you can see in this particular image here, this is a very severe hydronephrosis, right? There's the significant thinning of the renal parenchyma in this ultrasound picture. So when we think about hydronephrosis in our newborns, I just want to highlight that, you know, oftentimes the nomenclature can be tricky. We have dilation versus hydronephrosis. And as you know, some of our radiologists use hydronephrosis when they mean more significant dilation versus more mild. And so the nomenclature can be challenging. And we also know that dilation can vary quite a bit. So it's dynamic. So for example, in our early days after birth, when the urine output may be less, we know that it can underestimate the degree of dilation. In fact, that picture I just showed you was from a true patient that we followed who had very minimal hydronephrosis on the first 2 days of life. And by 3 to 4 weeks later, had this real severe dilated dilation and hydronephrosis. And then we know that there are also a variety of spectrum of severity, even in our most severe obstructions. So for example, children with post-urethral valves can have a more mild urinary tract dilation. Not all of them present with severe urinary tract dilation. So when we think about hydronephrosis, as I mentioned early on, or urinary tract dilation, a large percentage of these patients, it seems to be something transient or physiologic, that it does resolve after birth, somewhere between 50 to 70%. A smaller number will be like the patient that I presented, where they had a ureteropelvic junction obstruction. Some of the percentage, between 10 to 40%, may have vesico-ureteral reflux. And then there's a smaller number who have things like ureteral vesical junction obstruction, megagureter, and some of these less other common abnormalities. So again, because of the difficulties in communication with radiology, there is an effort, certainly in the US, to standardize our approach of how we define these urinary tract dilations by the severity of dilation, using something known as the UTD classification system, which is supposed to be uniform. And then this can actually help guide you when you are evaluating the patient postnatally to what your management. And again, I know you're going to have whole other talks about these topics, but just to highlight, in our case, our patient who had very severe urinary tract dilation, likely you're looking more for some significant abnormality such as reflux or UPJ obstruction. And in this case, this was the renal scan of our patient, where indeed this red line here is that left kidney, which was hydronephrotic. And you can see that there was no excretion after Lasix of the radioisotope, indicating obstruction. So this was a case of ureteral pelvic junction obstruction. The child underwent pyeloplasty by our urology team, did have some improvement of the hydronephrosis, and on follow-up at 3 years of age has only had one urinary tract infection and is growing and developing well. So what went wrong in this patient's case? So I think that this is a space that we're still trying to understand better, all of the signaling processes and genetic factors that cause a UPJ obstruction. We do know that there's this adynamic or hypoperistaltic area of the ureter that is often the cause of the obstruction. And I think as we are learning more about the gene pathways that regulate the ureteric development, we know that there are certain genes that can be upregulated in these ureters, and other genes that are downregulated in these ureters. But this is a space where I think I showed you earlier, there's less data on what are the gene mutations or genetic factors that cause UPJ obstruction. So it may be just a disruption of the normal development of the ureter that leads to this manifestation. All right, so I think that what I've been trying to highlight here is that when we think about CAKUT as a spectrum, we know that there are mild to severe forms. And a lot of this may depend upon the time point at which the defect is occurring. So when we think about the most severe abnormalities, they may come at the earliest time point, right? When the ureteric bud is first invading that metanephric mesenchyme, as I mentioned. If you have actual failure for the ureteric bud to reach the metanephric mesenchyme, then you get your renal agenesis. If you move forward kind of in that early differentiation process, right, in human gestation, where you're having the signaling pathways that drive the metanephric mesenchyme to convert into renal epithelial cells. And in addition, you have this signaling between the metanephric mesenchyme to the ureteric bud to drive ureteric bud branching. These defects at that time point are going to be what lead to your kidney hypoplastic phenotype. I didn't talk about it a lot, but if you have abnormalities of not only the number of ureteric buds, perhaps, but other gene abnormalities of the ureteric bud might also lead to sort of urectopic kidney or your horseshoe kidney, fusion abnormalities. And that may be sort of in the midpoint along the way of your kidney development pathway. Then when you look a little bit later on, right, when your urethra is forming, this is when you're going to start having your posterior urethral valves. And again, I did not talk a lot about this. There is still not yet very clear understanding of all of the genetic factors that drive posterior urethral valves and obstruction of the urethra, which, as we know, is a very important cause of CAKUT that leads to end-stage kidney disease in a substantial number of infants. But again, if this happens, this is happening a little bit later on during the course of development. but again, can have very severe manifestations due to the obstruction and blockage of both kidneys. And then when we think about sort of the last bit here, we have our nephron number and our determination, which really is occurring across the spectrum. I think I highlighted in that very first case, right? We potentially have babies that are born preterm. Perhaps they had abnormalities of their placenta that might affect their nephron number because of effects on ureteric branching. But then if they are born in that 25-week gestation period before the completion of nephron development, they're exposed to extrauterine factors that may ultimately decrease their nephron number. So we really have a broad spectrum of everything from complete lack of kidney to abnormal kidney formation with dysplasia, to abnormalities of the ureter and drainage system, to really a manifestation which may be smaller numbers of nephron, decreased nephron endowment, which sets up these children for future risk of kidney disease. And then again, just to highlight this in a different way, when we think about these different spectrums of abnormalities, this is again your sort of hypoplastic kidney, just a small kidney where the glomeruli themselves may appear normal. There's no dysplastic tissue. However, this is a patient who may have higher risk because of decreased nephron endowment of chronic kidney disease. You have your multicystic dysplastic phenotype, which I mentioned, which when it's unilateral, there is higher rates in some of these patients when you look at long-term follow-up of chronic kidney and end-stage kidney disease, potentially because they, again, have lower nephron endowment. They only have a single kidney to compensate over time. We talked a bit about our duplex kidney. Again, here, this is the classic one where you have obstruction of the lower urinary pole that is ectopic and reflux into the upper pole. This is a case of bilateral reflux, as in the case of our patient with a PAX2 mutation, renal coloboma syndrome. Here is a picture of our uretropelvic junction obstruction. And then this is a case here showing you a posterurethral valve. So really a full spectrum of CAKUT that I think you will learn a lot about in the upcoming webinar. So in summary, I hope that I highlighted the fact that we know that CAKUT is common, right? 1 in 500 babies have at least one thing abnormal with their kidney, and that does not even include those children that are born preterm and may have abnormalities due to the timing of their birth. And it can range from really mild cases, that fetal dilation that resolves over time, to our most severe cases of, for example, bilateral multicystic dysplastic kidneys, posterurethral valves, where you may have anguria and require dialysis in the earliest times after birth. And really the manifestation of CAKUT depends a lot upon the stage of development and the time point that is being disruptive in that process of nephron development. And as I think you'll hear more about in the subsequent sessions, copy number variants and genetic mutations, I think, are increasingly being recognized as causes of CAKUT, and they're important because we may have a better way to evaluate patients, especially thinking about monitoring for extrarenal manifestations. So thank you. And with that, I will take questions.
Yeah, thank you so much, Kim. This is such an excellent talk and such an excellent overview of CAKUT. I really like the way you explained, how normal development is, and then how, when the abnormal development is, how the CAKUT manifestations can be present. And I love your clinical cases. I think those are such a good examples of what we see as a pediatric nephrologist. And then, thank you again for an excellent summary of the CAKUT presentations. And we will go into more details in the sessions which are coming through. So, again, I know genetics is your, favorite topic. And again, thank you for sharing all those details with us. So we really appreciate that.
Great.
Yep.
Should I answer these questions in the chat, or how do you?
I can read those questions, and
Sure.
and then we can go one by one with them. So I'll start with the first question, which is actually in the chat, and then rest all questions are in the Q&A part. And Dr. Gauri Shankar has asked, in that. And his question is, how often should kidney function be evaluated in preterms during their childhood?
So this is an excellent question. And I think, as was mentioned, I am part of this neonatal kidney collaborative, which is actually international. There are members across the globe, and it's free to join. Babykidneys.com if you're interested, or babykidneys.org, I should say. But I think this is a really important question that I don't know that we have a great answer to yet, because I think we need more data to know how often and who should we be monitoring. I would argue, based on what we know now, that those children that are born extremely preterm, so for example, less than the 28 weeks gestation, I think at least monitoring at some point a creatinine and a urine. I mean, we know that up to 20% of them have abnormal kidney function at 2 years. I feel like that this should be a reason why we should be monitoring not only their blood pressure, which is already part of our current recommended guidelines, although not really fully implemented, at least in the US. So I think we are more and more moving to this idea that perhaps we should be monitoring kidney function. But I think the other larger question is it everybody? How many of the preterm babies should we be monitoring? Are those ones that had AKI at higher risk? And there's a big effort in the US to actually get more data, because obviously we also want to balance more frequent monitoring with the potential distress and burden on families, and of course, healthcare costs involved in screening. I think 10% of children globally are born preterm. So, which of these children should we be monitoring more closely, I think is a really important question. How often and when? I think for now, for the babies that I'm seeing in clinic, I'm typically checking their kidney function at times when blood work is already being done, for example, for lead screening around a year of age, as sort of an estimate, because if the kidney function test is reassuring, then that makes me feel better. But if it is abnormal, then that might be an indication for more screening later on.
Yeah. No, I totally agree. I think, the neonatal collaborative that you are part of, that should help us answer some of those questions and come up with some guidelines that how frequently we should be testing them. And I totally agree. I think, having universal screening, that may not be required. And I think we may have to come up with certain criteria, which are the kids at high risk of AKI and chronic kidney disease. And then we screen those regularly. So thank you for that. It seems, creatinine is the hot topic. Everybody do want to know about creatinine and outcomes. So the next question here is, how large is the discrepancy in U25 versus bedside Schwartz in your practice? Which do you use personally?
Yeah, this is a great question. And actually, we had a very nice session at our recent ASPN meeting talking about the U25. So I think I should say that U25, but just like all of these estimating equations, was based on the chronic kidney disease in children study, the CAKUT study. So it is, generated, of course, mostly from measured GFRs in children with chronic kidney disease. And thus, like any other equation that is then being applied to the general population, it may, it's likely to be less precise in predicting the estimated GFR, may be less predictive of true GFR in those children that have a higher GFR. And so I think one always has to, recognize that, it's really been validated quite nicely. It's as being a better predictor, particularly if you combine, which we are more and more doing in the US, the creatinine and using cystatin C in the formula to predict GFR. That is probably the most accurate in children where we know they have CKD. When you apply it to the more general population, as we did in the NHANES study, you can see that it will be more sensitive in a way. It'll identify more patients potentially as having impaired kidney function. And the discrepancy depends a lot upon the age. So the big difference between the two formulas is that the U25, the constant variant, or the K, varies with age and sex over time, so that instead of just 0.413 times the height in serum creatinine times the height in centimeters divided by the serum creatinine, that K actually changes. So the difference, the variance between the two actually depends upon the age of the patient. The biggest differences are in the less than 5-year-old and the teenage group in general. And that was actually shown by the study itself. So what do I do personally? I honestly calculate both. And I guess I would say I feel reassured. For example, if I have a kid where their creatinine is elevated, but I send a cystatin C and the estimated function by cystatin C is normal, that is more reassuring to me than the kid where when I do all of the formulas, the GFR is decreased. In general, I always am cautious with telling families, okay, this estimating gives us a decreased function. We'll have to monitor it and see what it is over time. As you know, things do change, especially in the infant period. We know that GFR increases in those first 2 years. So I'm very cautious with saying anything about decreased function in that time period, because it really can change quite a bit over time. I hope that answered that question. It's hard.
That was a very good explanation. And I totally agree. I think, starting with a creatinine, that makes sense. And then once we know that the patient is chronic kidney disease state, then definitely, we have other markers that we can use as well. And cystatin C, at least we know that in US, it's more easily available now. And, again, in India, how easily it is available, you have to take that into account. And creatinine still is the easiest marker that we can do, any lab can do. There is standardizations for that. So I would personally, start with a bedside Schwartz, which is the easiest. And then once we know there is CKD state, and if you have the cystatin C and other markers available, then we can run a bunch of these other formulas that we can. So, and I'll continue with the theme of creatinine. There is one more question I'll address related to creatinine. So it says, how long does preterm babies take to normalize their creatinine levels?
Right, that's an excellent question. So it also depends quite a bit on the gestational age. So we know that it is slower and takes longer for the most preterm babies to reach, quote, their nadir creatinine. I think the other big challenge in this space is that we also know that there is a very high rate of acute kidney injury in preterm babies. So what is normal is a little challenging because in some cases, children are being exposed, having been born preterm, they're, being exposed to the extrauterine environment is not normal. There are some very nice studies, if you're thinking more long-term, that shows that really you do have increase in GFR, up until, 18 months to 2 years, which is kind of what we knew back from the 70s about renal development in terms of functional development. So again, a little bit variable for how long the preterm infants will reach their nadir. It's going to take longer and slower in the youngest babies, even, 6 weeks longer, depending. And I think you have to give babies time, especially if you have a child that has, what looks like decreased function. I would give them time to see how they progress in that 18 months to 2 year time point before I would be 100% confident, particularly if it's mildly decreased, with labeling them as having CKD.
Yeah, thank you. And the next question is, and I'm going to reframe this question a little bit the way I understand it. It looks like there is, so I had experience with 2 siblings, 8-year-old and 3-year-old with contracted kidneys. So I'm guessing this is renal dysplasia. And one of the siblings had the previous blood transfusion, and both of the babies were preterm, 28 to 32 weeks gestation. So the question comes, can you slow the progression of renal function, and how?
Yeah, I think this is the most difficult. I mean, I am very excited by some other areas in our field where we have some newer therapeutics that we can be applying, things that have been discovered in adults. For example, SGLT2 inhibitors are kind of the new hot thing. But we don't have data at this time, I think, to say, kids that have, say, dysplasia and perhaps CKD, but but obviously not severe enough to need dialysis. Do we know if these newer agents will help? We don't know yet. I think the classic that I would say is, of course, ACE or ARB inhibition, blocking the renin-angiotensin system. There's certainly the ESCAPE study, which was this large European study of children with predominantly congenital abnormalities of the kidney and urinary tract, where they gave ACE or ARB, and they targeted ambulatory blood pressure monitoring with a mean at the 50th percentile, and they showed delay in progression. So unfortunately, I think that's the one space, I think, where we have an intervention that may at least delay progression. Certainly, I think good urologic care, depending on the situation, of course, also might have some impact on progression. But this is a space I wish I had something else to offer families. It is always difficult to say to a family, yeah, we don't really have any specific treatments to make this better. Yeah.
Yeah. Oh, and once we have it, we'll all be very happy. We can all take a big vacation. So,
yeah.
So next question is, and it's more about classification. I think it says, is juvenile nephronophthisis also included in CAKUT?
Well, that's an interesting question. I don't think of it classically in my mind as CAKUT, although you could probably argue, our, cysts, any like ARPKD or any of these, structural or abnormalities of the kidney that are related to genetic abnormalities. I mean, certainly they do not look structurally normal when you have nephronophthisis, but I think I just don't classically put it in that space. I think of CAKUT as mostly being things like, abnormal dysplasia or agenesis or reflux in like the cases that I presented.
Yeah, no, I agree. I think, nephronophthisis, even I consider it more like a ciliary defect or so. And, I don't know if this would actually go into more of a CAKUT kind of a classification, but the presentation could very much be CAKUT-like, as we all know. So I think, it's more about, I think, semantics and terminology. But classically, I would not put this in CAKUT. So the next one is very nice presentation. My question is association of CAK. So let me frame this. So is infection in early pregnancy associated with CAKUT?
I don't know that I have seen that association, at least that comes immediately to mind. I mean, certainly we know, as I think I mentioned, that maternal diabetes, obesity, various toxin exposures. I didn't go into all of them. Certainly we know, for example, people on ACE inhibitors, but infection does not immediately come to mind in my association. But not that it could be out there and I just haven't noticed it or seen it. Yeah.
Okay. And the next one is there any specific genetic panel to diagnose CAKUT prenatally?
So, I mean, I think that, this is a space I think that it's also changing a lot, right? There's even, depending on, where you are, I know that there are, kind of these various panels that some parents are getting, prenatally for, genetic evaluations that might include CAKUT genes in there. But, I think that what I understand is certainly that people are probably doing copy number variant analysis. That's pretty easy to do. They do like SNP arrays, looking for single nucleotide polymorphisms and these small deletions or insertions. I am not personally involved in advising genetic testings for that prenatal population. But nowadays, because there's also like, if you have significant numbers of abnormalities, there's even things like whole genome sequencing, depending on the resources and the availability. I mean, you're going to get everything from copy number variants to whole genome sequencing. We in the US have a number of renal panels that I'm not using prenatally, but we are using them after birth for genetic testing that are, these forms where they do whole exome sequencing and then they look at specific renal variants, 300 genes, but there are a variety of them. There's no one right way of doing this. And some people advocate for doing kind of more targeted testing, just those genes that you think might be involved. Other people suggest more broad testing because sometimes our phenotyping, nephronothesis is a great example. We had a patient where, they had ESRD of unknown etiology, and it turned out they had nephronothesis, and just our phenotyping was not good enough to make that diagnosis clinically before we did the gene testing. So there's not one panel that is perfect. And I think, you have to kind of work with your prenatal counselors for, how to maybe make it as targeted as possible, but also most informative. And I think it would have to include not just specific mutation testing, but also looking for copy number variants.
Yeah, no, thank you. This is great discussion, and I think we could go on and on, but I know it's 10:30, and for the sake of time, maybe I'll just take one last clinical question. And this question is, I have a child with left supernumerary kidney. I follow up every 6 months with yearly repeat of KUB, ultrasound, and BUN creatinine. I do a urine culture whenever the child has a fever. Any other workup to do for the follow-up for this left supernumerary kidney?
So I think that if the child had a febrile urinary tract infection, then any, associated kidney abnormality would make me more likely to do something like a VCUG to look for reflux. So just like if you have one abnormality, you might have more. I'm not even sure I'm not even sure you have to do every 6 months. I might do every year, like depending on how the kidney is looking and growing. But that is probably what I would do. And also how often I do ultrasounds depends a lot on how old the kid is, because of course your growth trails off the older you get. So I tend to do less frequent ultrasounds, as they get older. I'm going to let to you to see if you have anything else you would add to that.
I would do the same. So no, this is great. Again, thank you so much for joining us and, giving us all your knowledge and sharing your experience with us. And this has been an excellent discussion. This has been an excellent opening session for what is coming up in the next 8 to 10 weeks. And I apologize that we could not deal with all the questions. I think, I really like that this has been a very interactive session, and please keep your questions coming. We will try to address all the questions whenever the time allows that. So thank you so much for such an interactive discussion. And for the closing remarks, I'll hand it over to Dr. Kalavani.
Thank you for having me.
Thank you so much, Dr. Kim, for accepting our invite. And it was really a lively discussion. Thank you, Dr. Amrish. And from next session, we'll be having a polling session for the trainees, and it would be even more interesting and interactive session. Thank you so much. Thank you, Dr. Kim. Thank you, Amrish.
Yep. Thank you. Thank you, everyone. This will conclude our session.
Thank you. Bye-bye.
Thanks, Kim. Thank you. Bye-bye.
Thank you. Thank you so much for the invite. Hope it was.
Are we in the panelists one, or this is the?
This is a panelist.
This is a panelist. Okay. Yeah. Thank you so much, Kim. Really appreciate it.
I hope it hit on the points that you wanted for your future. Yeah. Okay. Good.
Thank you so much.
All right. Take care. Bye.
It was really very informative. Thank you so much. It was into depth and it was related with the case series. That was really a great discussion.
Great. Thank you. Thank you.
Thank you, Dr. Malwar. Have a good day.
Bye.
Thank you.
Bye. Thank you.